In this lecture, we'll be discussing different forms of anemia. So first, let's take a little bit of a look at hematology. So again, looking at the study of the blood. So hemoglobin is the part of the red blood cell that contains iron and is responsible for oxygen transport. Now, a normal healthy blood cell is going to contain 4 heme groups, as well as the globin, which is the protein component. Now remember, looking back at some of the different labs, we have hematocrit, which is the volume percentage of red blood cells in the blood. And then we have the plasma portion, which is the liquid portion of whole blood containing coagulation factors, and serum, which is the liquid portion of whole blood without coagulation factors. So remember, our red blood cells, or erythrocytes, contain hemoglobin. This is our main means of delivering oxygen to the tissues and comprises the largest percentage of blood volume. Now, what you'll typically see in the hospital setting, especially for the treatment of certain types of anemia, is packed red blood cells, which are red blood cells that have been donated, processed, and stored in a blood bank for transfusion. And so again, this is what you'll see when you see the when you go to the one blood truck, when you see the after they've been processed, of course. But this is when you see they're much smaller in volume than you realize. Now, some of our other lab components, we have the mean corpuscular volume. And so this is the measure of the average red blood cell volume. So this is how, in essence, the volume of a cell. And so this is part of the CBC, the complete blood counts. We also have the mean corpuscular hemoglobin. And so this is the average mass of hemoglobin per red blood cell in a sample of blood. And again, this is also found in the CBC. And again, we're looking for, there should be 4 heme groups. So again, if there's less hemoglobin, then we know that something is wrong within that blood cell. Some other terms to know, so we have hematopoiesis, which is the production of blood cells, and then specifically we have erythropoiesis, which is the production of red blood cells, and so we'll talk about this is regulated by the kidneys. We'll talk about how that works. And then you also have leukocytopoiesis, which is the production of white blood cells. All right, so taking a look at anemia. So remember, anemia is of the blood, so this would be without of the blood or without the blood. But again, we know it's not quite what it means. So here we have actually a deficiency in the size or number of red blood cells or the amount of hemoglobin they contain. And so this results in limited oxygen and CO2 exchange between blood and tissue cells, with fatigue being our #1 most common symptom of anemia. You're not getting enough oxygen, so you're tired. Now, all anemia is characterized by a decreased hemoglobin and decreased hematocrit upon lab analysis. So we'll take a look at some nutritional anemias. So again, and we'll talk about this, is there's some anemias that we can treat and some that we can't as a nutrition provider. But we'll be taking a look at inadequate intake and the resulting anemias from a poor intake of iron, protein, and then our vitamins being B12, folic acid, B6, and vitamin C, copper, and manganese. Now, there are other types of anemias that can have other causes. So for example, blood loss due to hemorrhage, surgery, accidents and trauma, ulcers or hemorrhoids, or esophageal varices. Again, it's not that these aren't important, but again, they're not really treated from a nutrition standpoint, they're treated from a medical standpoint. There can also be genetic abnormalities, chronic disease states, or drug toxicity. So again, looking at the classification of our nutritional anemias, so we have based on our cell size, so we have macrocytic or large cells, normocytic or normal cell size, and microcytic small cell size. We can also classify our anemias based on hemoglobin content, so we can have hypochromic or low color or pale color, or normochromic, which is normal color. So looking at macrocytic anemias, we'll see larger than normal red blood cells with increased MCV and MCH. With microcytic anemia, we have smaller than normal red blood cells, so we'll see decreased MCV and MCH. With normocytic anemia, we will see normal-sized red blood cells with normal MCV and MCH. Here's a nice cheat sheet looking at macrocytic, microcytic, and normocytic anemias, and again looking at underlying causes, clinical syndromes and causes, and the treatment options. Now, some of the general clinical signs and symptoms of anemia. Now, again, these can also be caused by many other things, so we have to look at it in context along with labs, etc. But these are things like fatigue, lethargy, chelosis, glossitis, poor skin pallor, pale sclera, spoon-shaped fingernails, clubbing of the joints and digits, cold extremities, numbness of extremities, muscle aches, difficulty concentrating, sleepiness, irritability, general malaise, GI distress, reproductive dysfunction, and cardiovascular complications like tachycardia, trouble breathing, and chest pain. Now, how do we look at iron status? So again, we've discussed this previously looking at the lab assessments, but again, just as a review and going a little bit more in-depth specifically on iron, so we have serum ferritin, which is our storage form of iron. We'll also take a look at our total iron binding capacity, and that's the capacity of transferrin to take on or become saturated with iron. We have transferrin, which is the transport protein for iron, and transferrin saturation, which is the amount of iron bound to transferrin and is an indicator of iron supply to tissues. And so what this is so percent transferrin saturation is serum iron divided by iron binding capacity times 100. So some of the nutritional anemias that we'll be reviewing are iron deficiency anemia, folate deficiency anemia, B12 deficiency anemia, anemia of protein energy malnutrition, Copper-Deficiency Anemia, Sideroblastic Anemia, and Hemolytic Anemia. So first, looking at iron deficiency anemia. So causes include blood loss, inadequate intake, inadequate absorption, increased needs, inadequate utilization, increased excretion, mineral excesses or competition, and contaminants. So iron deficiency in men is usually due to blood loss. Women can develop anemia as a result of heavy menstruation, and iron deficiency can cause reduced immunocompetence, resulting in frequent infections. Now, we also know that a lack of iron in the brain alters dopamine production and movement and may result in restless leg syndrome. Looking at contaminants, lead paint has been linked with anemia in children, and iron deficiency anemia and lead poisoning is associated with impaired cognitive function and neurological damage. Iron supplementation in these children, though, has led to improvements in mental and motor development. Other things we see, according to NHANES, is that overweight children are twice as likely to be iron deficient, as they make iron-poor food choices and instead are typically eating foods higher in fat. So, for example, French fries, potato chips, etc. are high in calories, but low in iron. Other causes include things like pica, so eating non-nutritive substances such as lead paint chips, clay, or dirt. Thought to result from iron or other mineral deficiencies, it is believed that deficiencies may play a role in causing cravings. We also see pagophagia, or eating ice, which is common when iron deficiency begins causing neurological impairment. As iron deficiency becomes more severe, defects arise in the structure and function of epithelial tissues, especially the tongue, nails, mouth, and stomach. And so what we'll see is pale skin, the lower eyelid will be a very light pink, the tongue will appear smooth, waxy, and glistening. In the mouth, you may develop inflammation, redness, and burning. In the stomach, inflammation and a lack of stomach acid. And the nails may develop a flat, thin spoon shape known as koilonychia. And so here you can see, so especially on the thumb and index finger, they essentially, instead of becoming convex, become concave and spoon-shaped. As anemia progresses and is untreated, cardiovascular and respiratory changes occur and may eventually lead to cardiac failure. Iron deficiency decreases immune function, and infection decreases the rate of iron utilization. So again, it becomes this circular worsening pattern. Increased occurrence of comorbid conditions are also associated with iron deficiency. Looking at diagnosis of iron deficiency anemia, so the most useful labs that we'll want to see, so we'll see ferritin will be decreased, transferrin will be elevated, and iron will be decreased. Now, why is hemoglobin not a suitable diagnostic criteria on its own? As it does not distinguish between the other types of anemias. So again, the way we look at this is we'll see that hemoglobin and hematocrit will both be low, which tells us the patient has some kind of anemia. We will also see low MCV and low MCH, which tells us this is some kind of microcytic anemia, which is typically iron deficiency. And then looking at iron binding capacity, which will be high, showing that the transferrin receptors are elevated. And again, we'll see, looking at our ferritin, transferrin, and iron levels. So looking at the medical management of iron deficiency anemia, so again, first focusing on the underlying cause if able to determine. So again, especially if it's due to blood loss, for example, due to trauma, due to GI bleeds, etc. Those need to be corrected because again, even if we change the diet, if we provide supplements, again, until we treat the underlying cause, it won't be very effective. And then after we've treated the underlying cause, we want to focus on repletion of iron stores. And so this can be done with oral supplementation. Now there are different forms of iron, so ferrous is easier on the gut and better absorbed. So for example, ferrous sulfate. Iron's best absorbed on an empty stomach. And so we're looking at a daily dose of 50 to 200 milligrams in adults and 6 milligrams per kilogram in children. And we will see an increase in the number of young red blood cells after 2 to 3 days of supplementation. Now, again, the number one side effect, though, of iron supplementation is constipation. So again, we need to take that into account as, again, there's very likely to be a complaint from patients. Now, the other option is there is parenteral or IV iron. This is iron dextrin, but it's more expensive and less safe. So our goal is really to use oral supplementation unless it's truly an emergency or there's no other option. Now, something to consider when it comes to our supplements or our sources of iron is remember that we have our heme iron, which is found in meat, fish, and poultry. And so that's what we refer to as our meat, fish, poultry factor in heme iron. Leads to better absorption than non-heme iron, with about 15% of iron being absorbable. Now, non-heme iron is found in eggs, grains, vegetables, and fruits. This is about 3 to 8% absorbable. And so what we do see is vitamin C binds with iron, especially these non-heme sources, to form a readily absorbed complex. So again, taking iron with an acid source, so what's commonly recommended is orange juice, can further increase absorption. Now, vegetarian diets with insufficient heme iron, so again, because they're obviously not consuming animal flesh, we need to consider that non-heme plant sources of iron have lower bioavailability. And so foods are often fortified with iron, but we just need to make sure that our client or patient is aware of this and making appropriate choices. Now, other things that are inhibitors or can interfere with iron absorption, these are things like carbonates, phosphates, oxalates, and phytates. And excessive intakes of minerals such as calcium, zinc, copper, or manganese can interfere with absorption, and we want to avoid heavy supplementation of trace minerals. And so what this has to do with is that because iron typically has a 2+ charge, there's a specific transporter which is DMT2 or divalent metallotransporter 2, which is what all of these minerals compete for. And so because they have the same electrical charge, right, basically in essence the transporter gets clogged up. So if it's fully saturated with zinc, there's no room for iron or vice versa. Now on the flip side, what if we get too much iron? So there is such a thing as iron overload. So excess iron is stored as ferritin or hemosiderin. And typically 1 milligram of iron is excreted per day through the GI tract, urinary tract, and skin. And individuals with iron overload excrete via the feces increased amounts of iron to compensate. Excessive iron intake is usually due to accidental incorporation of iron in the diet via environmental sources, including foods with iron-containing soils or using cast iron cooking vessels. And excessive intake is from things like iron supplemented foods, multivitamins, or individual mineral supplements. And this is why you'll see, so this is the major difference with things like Centrum Silver versus regular Centrum, or your other multivitamins, is one is typically iron-free and one is not. So going more into iron overload and looking at a specific form. So here we have hemochromatosis. And so this is iron overload that causes progressive hepatic, pancreatic, cardiac, and other organ damage. And that's because the regulatory mechanisms for iron are inoperative. And so this is a hereditary form, so this is a change in the HFE gene. And individuals with hemochromatosis absorb 3 times more iron from food than those without hemochromatosis. And so these patients can die from iron overload unless they donate blood regularly. And so we'll talk about that medical phlebotomy. So men are susceptible, and this is typically who you'll see hemochromatosis in, and women are at greater risk after menopause, right, or the cessation of menses. Now it's often underdiagnosed because, again, until there's a significant sign or symptom, organ damage, right, that brings you into the doctor, typically these patients aren't aware they have it unless they have an immediate family member who let them know that, hey, I have it, you're at high risk for developing it. So looking at our pathophysiology, so hepcidin is the peptide synthesized by the liver that functions to regulate iron homeostasis. And so this inhibits iron transport across the gut mucosa and inhibits the transport of iron out of the macrophages, which is our site of iron storage and transport. Now the hereditary forms, again, this is what usually is causing hemochromatosis, is due to this hepcidin deficiency. So the signs and symptoms of hemochromatosis. So early stages include fatigue, weakness, feeling cold, being irritable and unable to eat, and late stages showing chronic abdominal pain, aching joints, impotence, menstrual irregularities, and a slate gray appearing skin. And serious issues may develop including hepatomegaly, heart disease, skin pigmentation changes, arthritis, cancer, specifically colon cancer, proliferation of tumor growth, diabetes, increased risk for Alzheimer's and Parkinson's disease. So looking at the assessment or diagnosis, so again we have our laboratory analysis and we will see serum ferritin is increased, serum iron will be over 180 milligrams per deciliter, iron binding capacity will be decreased, percent transferrin saturation will be over 50 in women or over 60 in men, and we're likely to see abnormal liver function tests. Now we can do DNA testing to see if we have that hereditary or genetic form, but our liver biopsy is going to be our gold standard for the actual hemochromatosis status. So the medical management of hemochromatosis, we're looking at weekly phlebotomy. So once a week, the removal of 500 milliliters of blood contains approximately 250 milligrams of iron. And so in essence, you're donating a pint a week. Now again, you'll notice this is much more frequently than you would see from what people are typically allowed. And that's because these people's blood has that much iron in it. Other options include IV iron chelating agents. So we have, for example, desferrioxamine B, or calcium disodium ethylene diamina tetraacetic acid, EDTA. We can also use proton pump inhibitors. So again, this is going to decrease the amount of stomach acid. And again, remember that acid increases iron absorption. So by decreasing the acid in the stomach, we will then decrease the absorption of non-heme iron. We need to educate our patients on heme versus non-heme iron sources. So in a perfect world, these patients would ingest less heme iron from meat, fish, and poultry, and would get more of their food sources from non-heme sources. So they'd be ingesting, in essence, almost in a sense, a vegetarian diet, right? And they'd be getting non-heme iron, which is much less absorbed. We want to avoid iron sources such as cast iron cookware, avoiding vitamin-rich C foods and vitamin C supplements, avoiding or minimizing alcohol intake, avoiding heavily fortified foods, and avoiding a multivitamin with an iron or taking an individual iron supplement. Next, we'll take a look at Megaloblastic Anemia. And this is an anemia that results from the inhibition of DNA synthesis during red blood cell production. This is characterized by the production and proliferation of immature, large, dysfunctional erythrocytes with an abnormal shape in the bone marrow. So again, these large abnormal cells are known as megaloblasts. And this is associated with pernicious anemia and folic acid deficiency anemia. So it's important to diagnose the cause of the megaloblastic anemia correctly. So what's very important is we said that there's two main causes, pernicious anemia and folate deficiency anemia. Now, administration of folate will correct the megablastosis, which is the megaloblast, these cells will look normal in either folate or B12 deficiency. So folate will always fix the cell size, but it can mask the neurological damage of B12 deficiency, allowing the nerve damage to continue to progress, possibly to the point of irreversibility. So you have not actually corrected the B12 deficiency, but if you give someone folate, their blood cells will look better. So looking at folic acid deficiency anemia, so this is associated with tropical sprue, gluten-induced enteropathy, and some medications. Now again, we know that folic acid deficiency at the time of conception, right, or during the early gestational period can result in neural tube defects, for example, spina bifida. Other patients, though, to consider is that alcohol interferes with folate enterohepatic cycle and results in folate deficiency in patients with alcoholism. And so alcoholics have all 6 causes of folic acid deficiency simultaneously. And so here we can see these causes, which is inadequate ingestion, inadequate absorption, inadequate utilization, increased requirement, increased excretion, and increased destruction. Now we know that folate absorption occurs in the small intestine, specifically in the jejunum and the ileum, and enzyme conjugases located in the brush border of small intestine hydrolyzes the polyglutamate forms of folate from foods into the monoglutamate form. Now we know that zinc deficiency and chronic alcohol ingestion impairs conjugase activity. The monoglutamate form is reduced to dihydrofolate and then to tetrahydrofolic acid, THFA. MTHFA requires vitamin B12 to be active, and MTHFA is a cofactor for many reactions such as DNA synthesis. Now, a disease to consider is methylene tetrahydrofolate reductase deficiency, or MTHFR, which most people never forget because it has that acronym. So this is a genetic defect found in about 10% of Caucasians, and this may contribute to miscarriage and neural tube defects. It may also cause developmental delay, motor and gait dysfunction, seizures, neurological impairment, and clotting disorders. Something to consider is what's known as the methylfolate trap. Now again, as we discussed previously, with the relationship between B12 and folic acid, again, it's further complicated. B12 deficiency can cause folate entrapment in the metabolically inactive form of 5-methyl-THFA, which can result in folic acid deficiency. So here we can see that relationship where again we have our folate being trapped in the inactive form, the 5-methyl-tetrahydrofolate. Now, signs and symptoms of folic acid deficiency anemia include fatigue, dyspnea, sore tongue, diarrhea, forgetfulness, poor appetite, glossitis, and weight loss. So looking at the assessment and diagnosis of folic acid deficiency anemia, so the body stores of folate are depleted within approximately 2 to 4 months of a folate deficient diet. You'll see the serum folate will be less than 3 nanograms per milliliter, and red blood cell folate will be less than 140 to 160 nanograms per milliliter. Now, the red blood cell folate actually measures the body's stores and is a better indicator of deficiency than serum folate. And so macrocytic megaloblastic anemia will present with a decreased number of erythrocytes. So the medical management, so first we need to make sure that the megablastosis is folate deficiency and not B12 deficiency. And then 1 milligram of folate orally for 2 to 3 weeks replenishes folate stores, with 50 to 100 micrograms of folic acid is the minimum PO intake per day to maintain stores, with a recommendation of 500 to 1,000 micrograms if the patient also has alcoholism, and we recommend 600 micrograms during the first trimester of pregnancy to help reduce the risk of neural tube defects. We need to make sure that we educate the patient on sources of folic acid. So 1 fresh uncooked fruit or vegetable or 1 glass of fruit juice daily. So this one, for example, 1 cup of orange juice provides 135 micrograms of folic acid. Now we do need to consider that folate is easily destroyed by heat, and so this is why you'll see they've switched to lower temp pasteurization to help reduce the destruction of folate. And remember that in 1998, the FDA began requiring grains to be fortified with folic acid to help prevent neural tube defects, and so this is your enriched flour. So switching from folic acid to vitamin B12 deficiency, so vitamin B12 requires intrinsic factor in order to be absorbed. An intrinsic factor is secreted by parietal cells of the gastric mucosa and is found in gastric juices of the stomach. The actual B12 absorption, though, will occur later in the ileum. Now, the B12 intrinsic factor complex attaches to receptors on the ileal brush border, and this requires ionic calcium and a pH greater than 6. Then B12 is released and attaches to holotranscobalamin 2, or holo-TC2. The TC2 B12 complex can then enter portal venous blood. Now again, our deficiency of B12 leads to what's known as pernicious anemia. So this is a megaloblastic macrocytic anemia caused by a deficiency of vitamin B12 and is usually due to a lack of intrinsic factor. So strict vegetarians rarely develop vitamin B12 deficiency, and again, even if they were to, it is a process that takes several years due to such small amounts being needed. Other causes, though, include antibodies to intrinsic factor in saliva or gastric juices, small intestinal disorders affecting the ileum, such as celiac disease, tropical sprue, or cancer. Again, looking at the previous chapter and looking at medication, food-nutrient interactions, and then long-term ingestion of alcohol or calcium chelating agents. So here, looking at causes of B12 deficiency, again, we have that poor ingestion, absorption, utilization, requirement, excretion, and destruction. So the signs and symptoms of B12 deficiency include paresthesia, which is the numbness and tingling, often described as pins and needles. This is the same sensation that you get if you've ever sat on your foot awkwardly and then when you stood up, it started burning or tingling. Imagine that sensation in your hands and feet constantly, and this is due to B12 deficiency. We'll also see poor muscle coordination, poor memory, hallucinations, and if there's prolonged deficiency, the nervous system damage may become irreversible even with B12 treatment. So what will happen is that the damage, if I start providing the patient with B12, won't get any better, but it just won't get any worse. And this neurological damage can affect both the central and peripheral nervous system. Something to consider is that peptic ulcer disease and chronic gastritis are associated with hypochlorhydria, reduced production of intrinsic factor, vitamin B12 malabsorption, and pernicious anemia. And so studies show that the serum B12 levels of H. pylori infected patients are significantly lower than uninfected patients. And H. pylori contributes to autoimmune gastritis and pernicious anemia. Now the diagnosis of B12 deficiency, so we'll see low holo-TC2 values, less than 40 picograms per milliliter, and low serum B12. Now we also have the Schilling test, and this is a urinary excretion test used to determine if the B12 deficiency is caused by a lack of intrinsic factor. So the patient first ingests a radioactive B12 alone, and then again with intrinsic factor. Patients with pernicious anemia will excrete very little B12 during the first step because little or no B12 was absorbed, and patients with pernicious anemia will excrete normal B12 amounts during the second step with the addition of intrinsic factor. So looking at the medical management of vitamin B12 deficiency, initially the patient is going to need IM injections of 100 micrograms or more of vitamin B12 weekly, as oral B12 will not be absorbed with pernicious anemia. So once it's gotten to the point that it's full-blown anemia, we can't just take an oral supplement. Now what happens is that as, of course, the patient B12 levels return closer to normal, the frequency of injections is reduced to monthly, and then ideally, right, this becomes even less and less frequent as we now then consume a diet that has adequate amounts of B12. Now, assuming that there is no other issues, again, with intrinsic factor, etc., we should eventually be able to discontinue the injections. But again, if there is some anatomy changes, so for example, if somebody has had gastric bypass and or other issues along with, for example, damage to the ileum, then they may need continued B12 injections. Now, the response to treatment is evidenced by improved appetite, alertness, and cooperation from the patient. So looking at the nutrition therapy for B12 deficiency, we want to focus on a high protein diet of 1.5 grams per kilogram, as again, typically B12 rich foods are also high in protein. They go together. So this is things like beef, pork, eggs, milk, and milk products. And so those over the age of 50 are at risk for decreased intrinsic factor, where again, even if you're taking in the B12, they may still have issues. Now, patients taking metformin need to be aware that this reduces vitamin B12 absorption by 10 to 30% by decreasing absorbability by ileal cell surface receptors. But an increased intake of calcium can reverse this B12 malabsorption. So again, our patients taking metformin are patients with diabetes, PCOS, etc., may need to be taking additional calcium to help prevent B12 deficiency. Looking at anemia of protein energy malnutrition. So again, a diet lacking in protein is usually lacking in iron, folic acid, and B12, as protein is essential for the production of hemoglobin and red blood cells. And so for a patient with anemia of protein energy malnutrition, their red blood cells will be pale or hypochromic, but normocytic or normal sized. We also have copper-deficiency anemia, and so copper is essential for the formation of hemoglobin. So ceruloplasmin, which is a copper-containing protein, is required for normal mobilization of iron from its storage sites to the plasma. And iron cannot be released during copper deficiency, which leads to low serum iron and low hemoglobin levels in the presence of normal iron stores. Now, the deficiency, though, of copper is rare since only a small amount of copper is needed, and this is easily supplied by the diet. Looking at sideroblastic anemia. So this is characterized by a derangement in the final pathway of heme synthesis, which leads to a buildup of iron-containing immature red blood cells known as sideroblasts. And these red blood cells are microcytic and hypochromic, so they are small and pale. Now, the buildup of iron-containing immature red blood cells causes high serum iron levels and presents clinically initially as iron overload until you look a little more into what's going on with the patient. So again, this is why we have to look at the whole picture. And sideroblastic anemia responds to pharmacological doses of vitamin B6 or pyridoxine. Looking at hemolytic anemia. So this occurs when there are defects in the red blood cell membranes, and this leads to oxidative damage and to cell lysis, or cell breakdown, or the cells have in essence been cut open. So red blood cells are destroyed and removed from the bloodstream before their normal lifespan is over. Now, forms of this can be inherited or acquired, and this can lead to fatigue, pain, arrhythmias, enlarged heart, and heart failure. And so patients are responsive to vitamin E as a treatment. So the antioxidant involved protects the cell membrane against oxidative damage and increases the lifespan, right? So the blood cells had a shorter lifespan. We now, in essence, have reinforced their membrane, lengthening their lifespan, and reducing these symptoms, or in essence, reducing this hemolytic anemia. Now there's also some non-nutritional anemias that we'll briefly go through that you just may see. So again, just knowing how to treat them accordingly, or in essence, how to not treat them. And these are things like anemia of pregnancy, chronic disease, sickle cell anemia, sports anemia, and thalassemia. So anemia of pregnancy is related to the increased blood volume and is usually resolved with the end of pregnancy. And we also see increased iron demands during pregnancy. So remember that early on, when moms increase in what's known as plasma expansion. So what happens is that mom actually has more blood or fluids in circulation, but initially we haven't actually changed the amount of blood cells. And so what this does is, in essence, this is diluting the blood cells. And so it looks like anemia. But we now know that with good quality nutrition, as long as everybody's getting their normal amounts, taking their multi, this pretty much just resolves on its own. In the old days, though, we were making the mistake of giving people very high doses of iron, folate, B12, etc. And it turns out that that was not appropriate, and we didn't realize this was just a normal change in lab values due to pregnancy. Looking at anemia of prematurity, so low levels of erythropoietin in underdeveloped kidneys. And to remember that erythropoietin, or EPO, is the hormone needed to stimulate the production of red blood cells. And so the treatment is iron dextrins parenterally in an IV solution. So again, this is just something to be aware of. Typically, though, with these types of patients, you're more of just observing or serving in an ancillary role. But again, you would get more advanced training if this was a patient population you were wanting to work with full time. Looking at anemia of chronic disease. So this occurs from inflammation, infection, or malignancy with decreased red blood cell production. Ferritin levels will appear normal or increased. Serum iron and iron binding capacity are low. The blood cells will be normocytic, and so we want to make sure that we do not give iron supplements. And so we need to be careful not to mistake anemia of chronic disease for iron deficiency anemia. And again, so this is treated with recombinant exogenous erythropoietin therapy, or EPO or EPO. And these are drugs like Epogen and Procrit. And so again, these are drugs that actually cause you to make more blood cells. And so if you've been watching ESPN recently, of course, this is the drug that Lance Armstrong was abusing during his Tour de France runs. Looking at sickle cell anemia. So this is a chronic hemolytic anemia, also known as hemoglobin S disease. And this affects 1 in 600 African Americans in the US as a result of homozygous inheritance of the hemoglobin S variant. And so this results in defective hemoglobin synthesis, which is producing sickle-shaped or crescent-shaped red blood cells. And these can get caught in capillaries, in addition to not carrying oxygen as well. Now, this is usually diagnosed at the end of the first year of life, and it's very painful due to the occlusion of small blood vessels by these abnormally shaped erythrocytes. So here we can see the normal donut-shaped red blood cell versus the sickle cell-shaped red blood cell. And so what you can see is that because of their abnormal shape, they can cause blockages in very small arteries, and this occlusion or ischemia causes severe pain. Signs and symptoms of sickle cell anemia include acute severe abdominal pain, impaired liver function, jaundice, gallstones, deteriorating renal function, and low B6 levels are common. So the biggest problem is, you would think, is that in the year 2020, though, is that for the most part, we're just focused on pain management, and so some clinics are even just outpatient pain management, which is when somebody's having sickle cell crisis and they're in severe pain. You come to the hospital, you spend all day at the hospital, and I give you pain meds, then you go home. Then the pain gets worse, you come back, and I just treat you again. They don't even do inpatient because of the increased cost at some hospitals. Now, we need to be careful not to treat this with iron supplements, as sickle cell anemia patients are likely receiving blood transfusions frequently and are at risk for excessive iron. It's common to see decreased plasma zinc in children with sickle cell anemia, and zinc supplements may be beneficial. Looking at nutrition for sickle cell anemia, so a well-balanced food plan to provide enough calories and protein for growth and development, as sickle cell anemia patients are often underweight. We may need increased calories due to increased resting metabolic rate, as the patient is likely to be hypermetabolic due to chronic inflammation and oxidative stress, with a focus on foods high in folate, zinc, and copper. And a multivitamin mineral supplement is often recommended, just of course being aware of monitoring the amount of iron or choosing an iron-free multivitamin. We want to increase fluid intake and decrease sodium intake as needed to decrease the risk for vaso-occlusive events. So again, we want to make sure that we're not having vasoconstriction. We don't want to have the blood vessels right tight or high blood pressure. We want to keep things nice and relaxed. Emphasizing vegetable proteins, which are lower in absorbable iron, again, that non-heme iron. Avoiding iron-fortified foods, iron-rich foods, alcohol, and vitamin C supplements. And then on the flip side, if we're taking all of these steps, right, if we're the multivitamins free of iron, we're avoiding the iron-fortified foods, we're not eating too much meat, we're emphasizing vegetables, we just want to make sure that we don't go too far overboard and check for iron deficiency as well. So again, maybe we're too compliant. And again, avoiding alcohol, which can also increase iron absorption. Looking at sports anemia. So we do see increased red blood cell destruction at the initiation of a vigorous training program. So when somebody goes from couch potato to I'm going to start training for a 5K and they begin training intensely, you are going to see some red blood cell destruction. And so if we're concerned, we can monitor for serum iron, hemoglobin, and ferritin. But typically, not always, but typically when people start working out, they also say, hey, I'm going to start improving my diet. And so usually it's not too big of a concern. So athletes, benefit from consuming iron-rich foods, adequate protein intake, which again, when they change their diet, they usually start emphasizing a healthier diet, getting the right fuel sources. And if we're concerned about it, or this is an athlete at risk, we want to avoid tea, coffee, antacids, H2 blockers, and tetracyclines. And iron supplementation is typically not necessary unless they also have a true iron deficiency. But so what you'll see though is we kind of have this perfect storm because our at-risk athletes are going to be females, vegetarians, those in endurance sports, and those entering growth spurts. So you kind of have this perfect storm, right? Where if you had a 15-year-old female who's going to start going out for cross country, and all of a sudden you now have endurance, vegetarian, female athlete who's kind of at a growth spurt or ending a growth spurt, and you have this perfect storm. But again, just any one of these factors, as long as they're improving their diet and they have an adequate diet, again, should typically resolve as the body adapts to the training load. Looking at thalassemias. So this is a severe inherited anemia due to defective globin formation in hemoglobin. The red blood cells are microcytic and hypochromic, and this mostly affects those in the Mediterranean region. Now, increased iron absorption and progressive iron deposition occur, resulting in oxidative damage. This can cause dysfunction of the heart, liver, and endocrine glands, and these patients require transfusions to stay alive, along with iron chelators to help prevent the buildup of iron. So let's take a look at some practice questions. So the type of anemia caused by iron deficiency, I know what you want to say is iron deficiency anemia, yes. But what do these cells look like? And so this is answer choice C, microcytic anemia. Number 2, the form of iron that is absorbed best is blank iron. And if you thought this was a trick question, you were right. So depending on how the question is asked, if we're looking at supplements or at a chemistry standpoint, it is going to be ferrous iron. So again, you would have to read the question type. Now this question type is purposefully generic so that you could not answer this correctly. But on the RD exam or on a test, right, you would have to look at the types of answers and the exact wording of the question. So if we're looking at the chemical form, it's going to be ferrous. However, if we're looking at animal versus non-animal, if we're looking at specific foods, and for example, you're given a list of foods, spinach, broccoli, I don't know, mustard greens, and steak, then it becomes heme iron. So again, this question is purposely vague on the RD exam or in other sources. Again, you will just need to check the types of answers and the exact wording of the question, but it is either ferrous or heme, depending on the question. Number 3, the type of anemia experienced by people who lack intrinsic factor. So if I do not have intrinsic factor. This is megaloblastic macrocytic anemia. As again, this is the type of anemia that develops when someone has pernicious or B12 deficiency anemia. Number 4, macrocytic anemia may be caused by deficiencies of blank. And this is answer choice B, folate, B12, or both. And number 5, H. pylori is associated with and this is answer choice A, pernicious anemia. All right, so take a look. We're going to have some case studies, so we will be discussing these during the Zoom session. So you'll see there are several cases if you would like to take a look. So again, we'll be discussing the patient's background as well as their lab profiles. So we'll be talking about the diagnosis and then referring back to the slides to look at the treatment. Now, some of these may have medical treatment, which again is more of just FYI, and some of these may have nutrition treatment, which is what we would engage in. So again, feel free to look at these ahead of time, but we will be discussing them and answering them during the Zoom session. So thank you, and I look forward to your questions.